Doctors, ladies and gentlemen, Assalamu alaikum and good afternoon. We are going to start our post-lunch session on the portal hypertension. And I'm the moderator of this session, Dr. Sultan Ahmed Chandyo. I'm representing the PSH in the South and working as Assistant Professor of Medicine at Chandka Medical College, Ladkana. As all of you are knowing that portal hypertension is one of the deadly complications of liver cirrhosis. You and me are dealing the many patients of the portal hypertension and its complication in our daily life practice. So let us learn the different aspects of portal hypertension from the galaxy of our speakers. For the start of the session, I will request our speakers to occupy the seat of the chair. For that, I request Professor Mohammad Arif Nadeem Saab to occupy the seat of chairperson. Dr. Mohammad Arif Nadeem is the Professor of Medicine and Gastroenterology at Services Institute of Medical Sciences and Hospital, Lahore. Then I will request Professor Hafiz Mughis Athar. Dr. Mughis Athar is the Professor of Gastroenterology and Hepatology at Faisalabad Medical University, Faisalabad. And in the last, I will request the facilitator of this session, Dr. Asif Gul, to occupy the seat of chairperson. He is the Professor of Gastroenterology at Services Hospital, Lahore. Dr. Asif, please. So with the permission of the chairs, dear audience, I will repeat certain rules that as we can complete our session with the time. I request all the audience that you write down your questions and make this session interactive. Write down the questions on the paper and please provide this to our IT team. And I will again request the speakers to be on the time. So for the first speakers, we have the Professor Dr. Javed Iqbal FAROOQI Saab. He will talk on the portal hypertension and beta blockers, the current consensus. As all of you are knowing the Professor Javed Iqbal FAROOQI, he does not need any introduction, but for those who are unaware of it, Professor Dr. Javed Iqbal FAROOQI is the Professor of Hepatology and Gastroenterology in the Life Care Hospital and Research Institute, Hayatabad, Peshawar, Pakistan. He is also the CEO of the Al Hayat Clinical and Research Center, Dabgadi Garden, Peshawar. He is the ex-HOD of the medical unit at Government Lady Reading Hospital, Khyber Medical University, Peshawar. He remained the past president of the Pakistan Society of Hepatology, and Dr. Javed Iqbal FAROOQI has many of the national and international papers, many of the students in his credit, and research awards in the EPASIL and different international societies. He is among the authors of the national and clinical practice guidelines on different subjects in the Pakistan. So I will request Sir Professor Javed Iqbal FAROOQI Saab to come on the dais. Thank you very much.
Thank you, Dr. Sultan Chandio, for your kind introduction. As this topic has been communicated to me only yesterday, so I will try to do justice with the topic. The heading is the portal hypertension and beta blockers current consensus. As per my habit, I will start from the basics to make it easy for my PGs. I hope they are in the hall, and then we will go to the current consensus. What's the current standing of these? I showed this slide to you yesterday, the pathophysiology of the portal hypertension, the chronic liver disease, and the cirrhosis. And if I define the cirrhosis, it's a chronic liver disease characterized by portal hypertension. This will be the simple definition. The portal hypertension is the main culprit, the underlying way by which the decompensation happens. And if it is less than 5, it's normal, no cirrhosis, though the patient is chronic liver disease. But if it is more than 5, then it becomes a portal hypertension. But again, I discussed with you up to 10, it's insignificant, and more than 10, it is significant. And why I say this, when it is portal hypertension but less than 10, then there are no varices and no ascites. This is when it crosses the magic figure of 10 and till 12. This is the time when the varices develop. But when it increases about 12, then either the varices rupture or the ascites appear. So this is the breakup of this portal hypertension. And my PGs and my primary care physicians, where the facilities of this liver fibroscan and endoscopies may not be there, don't worry. If you use the APRI and FIP4, to great extent this correlates if your patient has got uh, portal hypertension to more than 10, less than 10 like here, and it can help you out. So this is not a very difficult task to classify your patients that what is going to be the underlying portal hypertension in these patients. I also shared this slide with you yesterday that out of 2,700 patients, around 1,200 they presented with ascites. So ascites is the first event of decompensation. It's true for our patients as well as anywhere. So just this is for my PGs and young colleagues. We know this is the portal vein and made from this superior mesenteric, and this is splenic vein supplying the 70% of the blood to the liver and then reaches and down to the sinusoidal level. And then to the sinusoidal level, the blood is drained back to the heart by the portal vein. This is the simple pathophysiological understanding. The Ohm's law, this is the physical law, but it is very well applied for the portal hypertension as well. It says that the voltage is directly related to the current and to the resistance. And when we convert it to the portal hypertension and medicals, then the pressure gradient through the portal vein is directly proportional. This is the outcome of the flow in the blood, the flow of blood and the resistance to the flow of the blood. And when we apply this Poiseuille law, then this resistance, it tells that the small decrease in vessel radius results in large increase in portal pressure. So these are the very basic physiological concepts, which I won't go into the detail of that, but you should be knowing that when we say the portal pressure decrease matters, yes, this really matters. So the portal pressure is equal to the blood flow multiplied by resistance. So any component, whether you increase the blood flow or you increase the resistance, you will find the portal venous pressure to be raised, to be on the right side. So when we say portal hypertension, either blood flow is increased or resistance is increased. And then the resistance to the blood flow is increased at 3 levels. This is, I'm saying, the broad spectrum, because followed my lectures probably is a non-cirrhotic portal hypertension. So here it will be easy to you to understand. And this resistance to blood flow may be pre-hepatic, hepatic, or post-hepatic. Let's see in detail. This is the first condition when there is increase in blood flow which leads to the portal hypertension. This is the portal vein, the blood flow is increased, there's splanchnic vasodilatation. So more blood is coming to the liver through the portal vein. So raised amount of blood volume in the portal vein leading to portal hypertension. Then coming to the increased resistance to blood flow. In the prehepatic causes, the most common cause is the portal and splenic vein thrombosis. And then in the hepatic, there is pre-sinusoidal, sinusoidal, and post-sinusoidal. The pre-sinusoidal, this is the sinus. The pre-sinusoidal, the most common cause is schistosomiasis, congenital hepatic fibrosis, and idiopathic portal hypertension. This is the one which we will be touching on, the sinusoidal level of increased resistance to the blood flow in the liver. And this is the most common cause is the cirrhosis. And here we see the distorted sinusoidal architecture, which leads to the increased pressure which is offered to the blood flow coming through the portal vein. And then the post-sinusoidal, again the veno-occlusive disease, this is at this level. and the post-hepatic is at the hepatic one level when there's a thrombus. So this is the simple classification of resistance or the causes of portal hypertension because of the resistance at what side it's present. Another concept is that of nitric oxide. Nitric oxide is a potent vasodilator in the body. So high concentration of nitric oxide in the blood will lead to vasodilatation, and low nitric oxide concentration will lead to increased sensitivity of vasoconstrictors and increased endothelial response to vasodilators. Let's apply this clinically to our patients. This is the patients, the intrahepatic circulation and the splanchnic circulation, and we see a paradox. In cirrhosis, we see a paradox. On the splanchnic side, there is increased concentration of nitric oxide, while in the intrahepatic side, we see decrease in the nitric oxide concentration. And what it does, it leads to vasodilatation in the splanchnic circulation. So more blood is being poured or coming to the portal vein. So the one component increased in blood volume in the portal vein is there. Second, it leads to the vasoconstriction in the intrahepatic circulation. Normally, the nitric oxide plays a major role in regulating intrahepatic resistance in cirrhosis. This nitric oxide activity is reduced, so leads to the vasoconstriction. This is a normal level vasculature. This is the cirrhotic, decreased number of nitric oxide. So there's intrahepatic vasoconstriction. So what happens? That increased intrahepatic resistance, one is irreversible. One component is irreversible, there is almost 70%. And this is related to the distortion of the liver macrovascular architecture, the collagen deposition, and the fibrosis deposition. Another component is reversible one. It's a dynamic one. And it is related to endothelial dysfunction, which leads to decreased nitric oxide concentration and increased release of vasoconstrictors like prostanoids, endothelins, and others. And this is the point when we will touching on when we come to the beta blockers. One will be that we'll try to reduce the blood flow into the portal vein, so the portal hypertension reverse down. Second, to relieve this reversible, address this reversible component, and thus the intrahepatic vasoconstriction is treated, so there is less resistance offered to the portal vein. So because of these two, then the portal hypertension will go down. This is again the basics concepts. We all know the alpha receptor, alpha 1 and alpha 2 receptors. They are distributed in the systemic and splanchnic blood vessels, and when they stimulate, they lead to vasoconstriction. And when they are blocked, the result will be unopposed the vasoconstriction, so vasodilatation will happen. While the beta 1 receptors, they are distributed in the myocardium, and when we stimulate these, it leads to increased heart rate and cardiac contraction. As a result, there is increased cardiac output, so more blood is being put into the portal vein. And by blockade of it, there will be reduced heart rate and reduced contraction, so decrease in cardiac output. Then the beta 2 receptors, they are distributed in the splanchnic blood vessels. And when we stimulate these, it will lead to vasodilatation. And when we block these, the result will be vasoconstriction. Now here comes the goal. The propranolol, the non-selective beta blocker, it blocks these beta 1 receptors and beta 2 receptors. So they decrease the cardiac output and contraction, leading into decreased cardiac output, and then the vasoconstriction. So the splanchnic vasoconstriction is there, blood is diverted from the splanchnic to the periphery, and less amount of blood is coming to the portal vein. So this is one mechanism. The carvedilol, it has got beta receptor blocker activity as well as alpha 1 receptor blocker activity. So it does helps the portal hypertension with this mechanism, as well as by blocking the alpha receptors, it also causes vasodilatation at this cardiac level, the hepatic level, so that dynamic or reversible 30% vasoconstriction or resistance goes down. So this is the main difference between these two, the carvedilol and the propranolol. Again, the same has been explained here. I won't go into the detail in the interest of time. So the non-selective beta blocker, where beta 1 receptors blockade, reduced heart rate and cardiac output with a decrease in flow of about 20%. Whereas the beta 2 receptors blockade, that is the non-selective beta blocker, cause splanchnic vasoconstriction due to unopposed adrenergic tone. And I discussed with you how it happens. With a subsequent additional decrease in portal-collateral blood flow of 15%, so total 35% reduction in portal venous inflow is there because of these two. But what we see, 15, so cumulative, but we see clinically it's a 15% reduction in the portal hypertension by using beta blocker. And why it is so? Because of the unopposed adrenergic tone, the non-selective beta blockers cause mild increase in peripheral and hepatic resistance. There is some sort of that, especially when you are using the propranolol. So what you get by at the splanchnic or the blood flow levels, 35%, it may not be translated to the clinically and it may remain only 15%. But when you use carvedilol, probably you get all that possible effect. So carvedilol is a non-selective beta blocker that has an intrinsic alpha-1 receptor blocking effect, which causes intrahepatic vasodilation and further decrease the portal hypertension. This is very important, that carvedilol is more effective in reducing hepatic venous pressure than propranolol at relatively high doses. This is what has been found. At low doses as well, which we use, at least I personally use in most of my patients, the very low dose, that is 6.25 milligram or 12.5 milligram. It does not cause hypotension. This is the point with it, but decrease portal pressure significantly more than propranolol. Studies has found this. So at the low dose, when you compare the low dose of propranolol and carvedilol, carvedilol has got an edge. It won't lead to hypotension, but it will lead to decrease in portal pressure. So the low doses cause only moderate decrease in cardiac output. So the point is that the carvedilol has got an edge when you are compelled to prescribe low dose because of the hypotension or intolerability of beta blockers by the patient. Clinical benefits of non-selective beta blockers, it stems from their ability at the portal venous flow as well as the cardiac resistance. The gradient, this is point, must be at least 10% of the baseline, preferably 20% or below 12 millimeter to prevent the first bleed. I mean, the pressure is more than 10 but less than 12, so you want that it should remain less than 12 or lower down. You need 10% or ideally 20% decrease, and to prevent the rebleeding it should be at least 20% or below 12. But good point is, when you the patient receives the propranolol, you get the 50% of this. 50% of your patients, they have shown that the decrease is there, and with carvedilol, 75% of the patients has been found that the response is there. So you don't need to check in each and every patient, do the hepatic venous pressure gradient. At least it's not available clinically here. So you can, these studies, you can help you out that when you are giving this patient these drugs, probably you are getting the response. So the this is the summary of whatever studies are there. I'll just briefly, for pre-primary prophylaxis, there is no indications to prevent varices or progression. For prevention of the decompensation, yes, no, it has been indicated. I'll share with you the studies. And decompensation, the first event of decompensation, as I told you, this is the ascites worldwide, and then is followed by the bleed. For prevention of the first variceal bleed, again it is indicated, the beta blockers use are indicated. For prevention of the rebleeding, that is the secondary prophylaxis, again it is indicated. For gastric varices, no strong evidence for the use of beta blockers. And for portal hypertension gastropathy, again these are indicated. So in the pre-primary prophylaxis and in the gastric varices, there is no strong evidence. Rather, in pre-primary prophylaxis, they are not indicated because there is one randomized clinical trial which failed to show prevention of the large varices and more adverse events. In the rest, the understanding is that you prescribe the beta blockers to them. I'll share this study with you, which was the beta blockers to prevent decompensation of cirrhosis in patients with clinically significant portal hypertension. This trial was a multi-center, double-blind, randomized controlled trial, and they included the patients with clinically significant portal hypertension but compensated cirrhosis. and they give the non-selective beta blockers to see what happens when you give and you don't give. This is the first randomized controlled trial to show the long-term treatment with non-selective beta blockers, and they decrease the clinical decompensation. And we know that this is when they follow the patient, ascites is the first. We used to give the beta blockers to prevent in the primary prophylaxis and secondary prophylaxis of variceal bleed. But this study extended the canvas, extended the spectrum, the possibilities or indications that no, even it delays the first decompensatory event of all in this patient, that is the ascites. 1/3 of the patients in this trial received carvedilol, 2/3 received propranolol. Their dose were adjusted based on the heart rate and blood pressure. Carvedilol, they found it's a much more potent non-selective beta blocker, and patients who received carvedilol had a greater portal pressure gradient reducing and had better outcome. This is when they found when there was no intervention, the 14% of the patient they had ascites, and the 3% of that patient they developed the varices. And when they compared the group where they give the beta blockers, what they found that incidence of decompensation or death significantly lower in the non-selective beta blocker group. So it was really helping these patients. A difference is mainly related to the reduced incidence of ascites. It was not the bleed, even the ascites. So the ascites was, the appearance was delayed as compared to the one who were not using the non-selective beta blockers. So what we were knowing that the prevention of the variceal bleed and to rupture, or if they are ruptured, to prevent the rebleed, this was additional benefit. Rather, this was the first benefit to be seen in these patients, that ascites appearing is delayed in these patients. Hemodynamic pressure, again, the non-selective beta blockers were having the better. And this is the cumulative incidence of developing decompensation, again in the beta blocker group, it was better in that. So this study concluded that long-term treatment with beta blocker can increase decompensation-free survival in patients with compensated cirrhosis and clinical significant portal hypertension, mainly reducing by the incidence of ascites. So the indications for the beta blocker has increased now, but we know side effects. I won't put the details, but you should be careful about these as well. So, dear chairman and dear colleagues, to sum up, the cirrhosis is the story of the portal hypertension, degree of the portal pressure. So in the compensated or asymptomatic, they've got longer survival because their portal pressure is low. But as the portal pressure increases, they develops the bleeding, ascites, hepatic encephalopathy, and their survival is compromised. And the magic figure is the 10 figure. So if we can prevent the portal pressure to be crossing this 10 figure, then you can help these patients to have good survival by delaying the onsets of the ascites as well as delaying the onsets of the variceal bleed. I also said yesterday, the cirrhotics are very delicate people. We need to give extra care to these patients. This is very important. So the take-home points, after a diagnosis of cirrhosis is made, the next step is to determine whether the patient has clinically significant portal hypertension or not. And for this, you don't need to do the HPVG measurements, all those things. Even by the EPRI and FIP4, you can be sure enough that whether my patient has got the clinical significant portal hypertension or not. I shared with you the first slide. And if so, if you think the patient has got clinical significant hypertension, then you start non-selective beta blocker to prevent the decompensation. Non-selective beta blockers prevent decompensation mainly through ascites. Ascites is the first decompensatory event, so it delays that in patients with clinically significant portal hypertension. So with this, I thank you all for the kind listening. Though this was communicated to me yesterday, I hope I've been successful to give the concepts of portal hypertension and what are the its adverse events and how we can intervene to have good impact on the survival of the patients. Thank you very much.
Thank you, Professor Farooqi Saab.